Many of us remember the actor Chadwick Boseman, star of Black Panther, 42, and Marshall, among others. Like many people, I knew that Boseman had been diagnosed with cancer and tragically died from the disease in August 2020. Earlier this year, though, his wife, Simone Ledward Boseman, shared something in an interview with The Today Show that caught my attention. Boseman was originally diagnosed in 2016 and had actually gone into remission. And according to Simone, when the cancer returned, it came as a complete surprise to both of them. When I heard that, I found myself thinking about a word we hear all the time when it comes to cancer: remission. For many of us, remission may sound like an ending, a finish line, a moment when the uncertainty is finally over. But the more I've learned, the more I've realized that remission can be something much more complicated than that. For some patients, remission isn't just relief. It's also follow-up scans, ongoing monitoring, fear of recurrence, and learning how to balance hope with realism. In other words, while remission may mark the end of treatment, it doesn't always mark the end of uncertainty. So how do patients navigate the emotional reality of remission and recurrence? Let's talk about it. My guest today is Dr. Elizabeth Kacel. Dr. Kacel is a Chicago-based licensed clinical psychologist and the founder of Pear Health Psychology, PLLC, cultivating purpose, empowerment, acceptance, and resilience among people facing cancer and other medical conditions. Dr. Kacel uses evidence-based psychological treatment approaches to help patients cope effectively and live meaningfully across all phases of cancer, from new diagnosis through survivorship. She has worked with individuals and families with cancer and other medical conditions for more than 15 years. Dr. Kacel completed her PhD in clinical health psychology at the University of Florida and a postdoctoral fellowship in psychosocial oncology at the Mayo Clinic in Minnesota. She has worked in top academic health centers and hospitals, contributed to 20-plus peer-reviewed journal articles, and participated in numerous local and national conferences focused on cancer psychology. Naturally, Dr. Kacel is the perfect guest to discuss this topic. Dr. Elizabeth Kacel, it's so great to have you. Welcome to It's Gonna Be Fine.
Thank you so much for having me.
Of course. So let's jump right in. And I actually want to start with a little bit of a story that I was thinking about when I was preparing. And that was, I remember when I was a kid in school, young, there was another student whose father was diagnosed with cancer. And I remember it being kind of a big deal, right? This wasn't common amongst, school kids. And his father was going to have surgery to remove the tumor. And my child brain at the time said, oh, no problem. They're going to remove the tumor. Cancer's not scary. He'll have surgery. They'll take it out. He's going to be fine. Mm-hmm. So obviously my adult brain knows that that's not how cancer works. But I think it might highlight a misconception that perhaps some of us have, which is treatment is the end of the story. So that kind of leads me to my first question for you. When people hear that someone has gone through, quote, successful cancer treatment or is in remission, what do they often misunderstand about what comes next?
There's actually a number of things about that anecdote that I would love to dig into in terms of how we as human beings and as our society process and understand cancer. What's interesting actually about what you said, that in your sort of child brain, you thought, oh, this is no big deal, is sort of the opposite of what most adults think of when they hear cancer. Whether it's treatable, curable, early stage, late stage, doesn't really matter. For most people, when they hear the word cancer, our minds immediately go to this collective unconscious idea around mortality. And even though we've made huge strides over decades in treating cancer, for most people, that's still the first thought that comes into their mind is, is this unfortunately going to end my life? But to go back to your question, what do people think, feel, and understand when they finish active treatment? It depends. For women who are diagnosed with a very early stage breast cancer, early stage at diagnosis is always better. It means we are not ahead of the cancer, but have caught on quickly. And before it starts doing its thing, we can really get it under control. So someone with early stage cancer may receive a very reassuring message from their cancer care team to say, hey, we're going to do a surgery, we're going to do some chemo or some radiation, and then most likely You are not going to deal with this ever again. That does happen sometimes, although I think doctors are, in my experience on the psychology side, shifting away from promising cure or promising remission, because the statistics are changing and we are seeing different rates of recurrence and much further out rates of recurrence, which also gets to your question about what does remission really mean? It varies, right? There are some cancers that our treatments are better at controlling the disease, and there are some cancers that our treatments are not as powerful in controlling them. So we have some folks who are diagnosed with a later stage cancer, perhaps colon cancer like Chadwick Boseman had, or lung cancer, or other types where the person may have to be on treatment for the rest of their life. Now, the fact that that option exists in some ways is a good thing, because there is a treatment that can control the disease for years. However, the treatment is not easy to endure, and so that creates a lot of challenges, because you can choose to take the treatment indefinitely, but some people say that it's not really a choice, that if you want to move forward and keep living your life, you kind of have to do it.
Does that mean that even if you're taking a lifelong treatment for certain cancers, are you in remission during treatment, or are you just never in remission?
So at one point in the past, people would finish their active treatment and then be told, if there was at that point no evidence of cancer, which is typically assessed through scans like MRI, CT scan, PET scan, or for the blood or hematologic cancers like leukemia, can be assessed through various biomarkers through a blood test. They would look for the cancer, and if after the treatment they saw no evidence of the cancer, then they would say, you're in remission. And a lot of people latched on to this idea that if you were in remission for 5 years, that was it, you were cured, you were never going to deal with cancer again. Unfortunately, that seems to be not so much the case for everyone.
Mm-hmm.
Most shockingly for me, I recently worked with a really lovely, incredible woman, but she had her cancer come back after 25 years.
Wow.
Now, I don't say that in wanting to scare someone who's in survivorship. Well, that could be me. This is just one example, and it's probably a very rare example. But I've heard a lot of healthcare providers shift away from this concept of remission to no evidence of disease, or NED, which means right now we don't see any cancer in your body. We're not saying there isn't any, and we're going to continue monitoring. So when someone finishes active treatment, there is a reasonable idea that, oh, thank goodness, I'm done. But what most of my patients and their loved ones realize is that when you're done, you're not really done. Because for many, there is a lifelong fear.
Mm-hmm.
What if I have to go through this again?
Yeah.
And it's not easy to just sort of put blinders on and go forward, because part of the protocol once you finish active treatment is intensive follow-up. Most of my patients will acknowledge that going through cancer is more than equivalent to a full-time job.
Mm-hmm.
The number of appointments, medications, rituals, routines, it's incredibly overwhelming.
I've heard even dealing with the insurance can feel like a full-time job.
Oh my goodness, yes.
You mentioned a couple of things that I want to dive into.
Mm-hmm.
One was fear of recurrence, one was survivorship. And I want to start with, I remember when you and I first got in touch, one of the things you told me was you did, I think, your dissertation on this specific
Mm-hmm.
topic, fear of
Yes.
recurrence. Tell me a little bit about what got you interested in that back when you were getting your PhD. Like why, because it seems like a pretty unique topic.
So fear of cancer recurrence is a multidimensional experience, which can include cognitions, thoughts, worries, physical symptoms and sensations like, oh, I have a pain in my back or my chest or my head. Does that mean my cancer is coming back? Mm-hmm. As well as behaviors. for example, self-examination or palpitation. And it basically is focused around the idea that a person experiences the medical trauma of being told you have cancer, going through the treatments, which can be very difficult, and really feeling psychologically and physically overwhelmed and in cases traumatized and really not wanting to go through that again, which of course is completely understandable. Mm-hmm. And so fear of recurrence is basically the experience of worrying and wondering, is this going to come back? And if so, when? And it can show up in all sorts of ways. When I was doing my dissertation, I needed to get a grasp of how common this is. So the short answer is almost everyone experiences it. The more complex question, which needs an answer, is to what extent and how does it impact the quality of their life?
Got it.
So I've worked with people who experience fear of recurrence immediately from the diagnosis through all of the treatment. What if this treatment doesn't work? What if it comes back? Fear of cancer recurrence that spikes at that point when they finish active treatment and are slowly shifting back into their normal life, and even years or decades later. So it really varies a lot. How does it impact someone? That can also vary. So for some people, it will be a thought that pops into their mind here or there a few times a week. For other people, it might be something on their mind every day. The most extreme example I can give, which thankfully doesn't impact people to this degree, is I worked with a gentleman several years ago who had an oral cancer. And he would spend hours a day in the bathroom examining his mouth and his tongue and his throat and everything like that, obsessively checking to see if there was any indication that the cancer was coming back. Mm-hmm. And so you can imagine that that was going to start impacting his day-to-day life if he was spending hours a day doing that. And so just like with any psychological condition or any mental health symptom, if it's starting to severely impact someone's day-to-day functioning, that is one example of a really good time to reach out for help and support.
Got it.
So the long answer is fear of recurrence varies in prevalence, in intensity, and how it's affecting someone's day-to-day life.
You know, you said something that I'm still thinking about, which is like, if you've had cancer and let's say you're in remission or no existent, I forgot what NED, I think is what you called it.
No, no evidence of disease.
No evidence of disease. Mm-hmm. Then I could totally understand, like, you get a headache and you're like, oh my God,
yes.
is this it? Right.
Yes.
Versus just maybe it's a standard headache that we all get. So
yes.
I can see that being incredibly like anxiety inducing. And
it's a huge, huge challenge for people. Because on the one hand, we teach people in general wellness and healthcare, know your body, be mm-hmm. attentive to how you're feeling, pay attention. And those are good things. But after someone goes through the trauma of cancer, it can often lead to what's called hypervigilance, which is when someone is particularly focused in on their body. And hypervigilance comes up in a variety of medical conditions and as a symptom of a variety of mental health disorders. But after cancer, it's like the brain and the body are trying to protect the person, not just physically, but emotionally from the shock of being caught off guard again. Mm. Because for many people, whether they feel ill or not prior to a cancer diagnosis, it feels completely earth-shattering. And that doesn't feel good. Right. That feels like a total loss of control, like the rules of the game are not what we thought they were. And so hypervigilance in many ways is not just to protect one's physical health, but to protect from the trauma of that shock of it coming up again.
Right.
And so you'll have people being vigilant to all sorts of things, like you said, from normal physical changes like sweating after exercise, increased heart rate, to miscellaneous stomach pains, headaches, joint pain. Catastrophic thinking is when your mind goes to the worst possible case scenario. Now, we all do that sometimes. Mm-hmm. Absolutely.
Sometimes multiple times
I'm
a
assuming
day.
You.
Yeah.
We all do it sometimes.
Yeah.
But when it becomes a pattern is when it can really lead to a lot of anxiety or even feelings of sadness or depression. So when we have someone who's gone through cancer and then is hypervigilant about their body, any symptom or sensation immediately sends the mind to that place of catastrophe. Oh my God, it's the cancer. The cancer is back. My treatment didn't work. Something is going wrong. And then, of course, that leads to all sorts of questions and concerns about mortality. So it's a really significant issue. What did I actually study in my dissertation about fear of recurrence? So in addition to being a psychologist, I'm also a certified yoga instructor. And I became a yoga instructor back in 2011. I learned about the use of yoga as what was then called a complementary and alternative therapy to help people manage stress, anxiety, and also to cope with chronic health conditions. Now we refer to things like yoga, acupuncture, massage as integrative medicine. And so integrative medicine is where we bring together sort of East meets West, but still holding on to our scientific background and principles. The way I got into all of this work in cancer psychology is personal. So when I was in college, my grandfather died from his 5th cancer diagnosis. And it wasn't cancer recurrence when it comes back. It was 4 or 5 separate types of cancer.
Wow.
I know. And towards the end of his life, I was already in college. I was studying psychology. And somehow serendipitously, I learned about this field of health psychology, which is another integration of biology and psychology and how we understand illness, wellness, disease prevention, disease management. And so that's when I decided to become a clinical health psychologist and to focus on cancer. I was very stubborn about that for many years. Mm-hmm. And I knew that I wanted to bring yoga in as a way to help people cope with the psychological impact of anxiety and depression living with cancer. So my theory was that yoga, which really is rooted in this idea of being in the present moment, of treating yourself with compassion and kindness, would help people manage anxiety about recurrence. Because anxiety about recurrence ultimately is intrusive thoughts about the future.
Yeah.
And if someone has the tools and strategies to be right here, right now, those thoughts about the future and the unknown, they don't necessarily go away, but they can soften. They can fade to the background, and they can have less impact on someone's day-to-day functioning. And so that was the focus of my research during my doctoral degree.
Yeah, wow. I was wondering too, when it comes to the patients themselves, mm-hmm. You mentioned when it gets to a point where you're not able to function in your day-to-day life, it's time to reach out for help. And I was wondering, is it usually the patient who's saying, I want to see a psychologist who specializes in this area and who understands cancer? Or is it are you part of their treatment team? So they have their oncologist and they have all their people who are supporting them. And then they say, we also want to bring in a psychologist. How does that work? Or maybe it depends.
It's a great, great question. In an ideal world, psychologists would be in every cancer center and honestly every hospital. And the reason I say that is because we are recognizing through research that psychological and behavioral components of health and illness are completely fundamental. People of certain demographics, for example, men of color, are more likely when they have a mental health symptom like low mood, low energy, fatigue, are more likely to present to a primary care physician than to seek out a therapist of some kind. And that may not be intentional, like I feel more comfortable with a doctor than a psychologist. It may be they genuinely believe they have a physical problem. It may also be that there is a stigma still in many communities about seeking mental health care. But that's the reason that I think psychologists should be in all hospitals and cancer centers, because physical health impacts mental health and mental health impacts physical health. Yep. And that's in very real ways. If someone has a dysregulated thyroid, too low of a thyroid functioning can lead to symptoms of depression, and hyperthyroidism, overactive thyroid, can lead to symptoms of anxiety and panic attacks. So it's very real, the relationship between physical and emotional. But to your question, in 2015, the Commission on Cancer, which is a national group that regulates accredited cancer centers, they basically said that it is mandated that all centers, as part of the accreditation process, have to assess for distress. And distress includes emotional distress as well as physical, spiritual, financial, etc. So because of that mandate, you have to have people who are qualified to assess distress. And ideally, it's going to be mental health providers, which would include psychologists, social workers, licensed professional counselors, etc. These days, because the need for this distress screening is so wide, other people are being trained, like doctors and nurses and others. And with good training, I think it's reasonable that many people in healthcare would be qualified to do it. But once you screen people for distress, you have to have somewhere to send them if they screen positively. So many cancer centers now do have psychologists and social workers integrated into their teams. And so the medical doctors, the oncologists, they have a general or specific sense of exactly who they need to refer to. So when I have worked in hospitals in the past, I was part of the cancer center staff. The doctors had an exact referral channel, and they would send people to us, myself and my colleagues, directly. However, there are also people who do not want to see a psychologist in the cancer center. One of the biggest reasons is privacy. So with our electronic medical record that most places have these days, my psychologist's notes from my visits with my patients are included in the general medical record, just like all the other staff at the hospital. For most people, they don't have an issue with that, and they actually recognize the advantages of that. Because if we're saying that physical health and mental health is fully integrated and dependent, then your psychologist knowing what's going on medically, and your medical doctor knowing how you're doing psychologically is actually really powerful and potentially protective and beneficial. So I'm a proponent of that when it is possible and when it exists. However, there's some people that feel that their podiatrist or their dentist in the health system really doesn't need access to their psychotherapy notes related to their cancer diagnosis. And so they may prefer to seek a therapist completely outside of their healthcare or health system. And I respect that. I understand that privacy is a fundamental issue, and everyone is going to be comfortable with a different model. But as a health psychologist who does really believe in that relationship between the physical and mental health, I support that integration.
Yeah. Part of me is impressed almost with patients that they think about that. Like, because I think it never even crossed my mind, like the notes part and who's seeing what. But the fact that they're so sensitive to that, I think says a lot about what they're going through.
I do too. Now, I will say that hospitals all around the country have different systems and models. And this is probably a whole nother topic around HIPAA, privacy, documentation, the Cures Act. Are you familiar with the Cures Act?
I don't think so.
So the 21st Century Cures Act has been implemented on the federal level over the last several years. And it's a law that basically says patients are entitled to review their medical records and notes.
Yep.
And so that was a huge change. That began rolling out when I was on my fellowship. And so for the first time, clinicians of every kind were aware that the moment we complete our legally required clinical documentation, it goes to our patients who then can review it.
Two quick things about that.
Yeah.
I was smiling when you were talking about the notes because I love reading the clinical notes because there's two things. There's like the after visit summary, which just lists like the medicines. It doesn't go into detail, but then reading the notes.
Yes.
I have never felt more important as a person and a patient reading those in my experience so far. I'm sure it's different, but the way that the doctors talk about the patient in like the way they refer to them, the way that it just seems like they care about what the patient's going through. And I read these things and I'm like, wow, my doctor really cares. Like she cares that I'm having this particular discomfort, or almost more than I do sometimes, how seriously they take it. So I love reading those notes.
I am thrilled that you've had that experience. I don't know that that's the norm. I think a lot of lay folks who have never worked in healthcare are often put off by sometimes very brief clinical language. Like, for example, a lot of times we refer to people as patient, right? Patient reported X, Y, Z. A lot of people immediately brusque at that and say, well, that's like dehumanizing.
It's not my name, right?
And I can understand that. Personally, I try to always say Mr. X, Miss Y. But yeah, the pressure on documentation is another topic.
Yeah.
We're hitting a lot of big topics that we can
Yes.
talk on. And sometimes it is easier to streamline things. But, it can also say patient or Mr. X was resistant to hearing this information about their diagnosis. And that is the clinical judgment of the person who wrote the note. But for a person to see that, they may not take very kindly to that. They may feel that it minimizes the complexity of what they're going through.
Yeah.
So clinical documentation is a massive, massive topic, not just in cancer, but in all aspects of healthcare.
Yeah. I also one time had a doctor. This was, I think, my primary care doctor. This was 2023 maybe. So I don't know how long after the Cures Act that was. But she warned me because we were talking about a specific condition and she was going to prescribe a medication. And she's like, in order for the insurance to cover this, I need to document these things, which some people, when they read it, it can cause distress or whatever, right? And so she's like, if you read it, you're going to see it. I just want to let you know, don't worry. And I thought that was very thoughtful. Yeah.
Really thoughtful.
I've definitely had to look up and Google some of the acronyms that I didn't know what they meant because there's a lot of shorthand that's used.
Which would lead us down quite another large tangent, but people having access to all this information and not always knowing what it means, and then turning to Google initially and now turning to AI, this is becoming a huge field of study in of itself.
So you mentioned this word a few times. And in my preparation for the episode, I kept coming across it as well. And I actually didn't maybe even understand or fully understand what it meant. And that's the word survivorship. Because when I saw it, I was thinking, is that survivorship for the patient? Does it apply to the families? What does that mean? So can you help us understand what survivorship is and how it applies to cancer patients and their families?
Absolutely. So depending on the context that you look, a person is considered a cancer survivor from the moment they're diagnosed. We can say that they're in survivorship, they're a cancer survivor. And in the past, we would only look at survivorship and quality of life issues after someone reached that point we were discussing previously about the end of active treatment. And we'd say, okay, now you're a survivor, go forth and prosper, which is much easier said than done. And that is how the field of survivorship has really blossomed out of an immediate and crucial need to recognize that finishing active treatment is in some ways really just the beginning. Cancer treatments are incredible medical discoveries and advances that do save lives, for sure. However, they are very toxic with many side effects and many challenges. So, for example, some breast cancer patients are at a high risk for cardiac disease. So when a person finishes and stops those cancer treatments, either the radiation or the systemic one, and it's particular ones, not all, that can be cardiotoxic, they then require cardiac monitoring, possibly for the rest of their life. And people used to say, well, you should just be happy to be alive. Everything else is, gravy. But we really do not feel that way anymore. You don't have to pick between being happy to be alive and wanting to enjoy the life that you have.
Yeah.
So there is this emphasis starting earlier and earlier, closer and closer in proximity to diagnosis, that yes, we are protecting someone's life and longevity, but we are also protecting the quality of their life. And so survivorship programs are rapidly growing in cancer centers, focused on addressing the person holistically. And I mean the whole person, right? From your bone health, which can be impacted by cancer treatment, to your heart health, to your mental health, And so depending on where you go, you can have a survivorship program that is really integrated, where you have all of these different specialists working together under one roof, so to speak. Or you can have a survivorship program that's a little bit more siloed, where we know what specialists we need to take advantage of their expertise, but they all sort of function in their own practices separately.
And I imagine cancer causes maybe some of these side effects like you're talking about and affects other organs in the body. But I also imagine people get diagnosed with cancer who have already had pre-existing chronic conditions that the cancer can then affect the treatment they're used to.
Definitely. That's definitely true. The first example that pops into my mind is diabetes. So obviously a very common condition in the US and abroad. And because of the way that certain chemotherapies will affect the body, there's some commonality of using steroid medications, for example, dexamethasone, as what we call a pre-medication. So something that's taken before the cancer treatment is received to sort of dampen down the body's response and make the treatment a little bit more tolerable. However, steroids can actually influence blood glucose,
which goes up, right?
It can, yes, which can impact diabetes management. However, on the opposite side of things, other systemic treatments can really make it difficult to eat, can cause a lot of vomiting, which can also impact nutrition and electrolytes, which can also make managing diabetes really tough. So that's one example of someone coming into cancer with a chronic condition. On the mental health side of things, since we're on the topic of steroids, for someone who has a history of, whether diagnosed or not, bipolar disorder, steroid medications can lower the threshold, which means increase the risk of experiencing a manic or hypomanic episode. And so it's a really another very important example of how medicine and mental health have to work together, because steroids can be, for some, a very important part of their cancer treatment regimen. And we need to be aware of someone's mental and physical health history when we're giving these medications, so that we can keep an eye on them and support them if some of these concerns or complications emerge.
It's like why the integrative piece is so important, because they all affect each other and you can't just like do it in silos.
Exactly.
Okay. So you mentioned also, we talked a little bit about when a patient might work with a psychologist, where they might work with them. Do you find that most people tend to do it earlier in their treatment or maybe later? What's been your experience with, at what point do you meet the patient first? Where are they in their cancer journey?
There's sort of a joke among psychologists that we annoyingly answer most questions with, it depends.
Yes.
So there are some people who will come to me later in their journey. They are weeks or months into treatment. They're done with treatment in survivorship and are struggling. And they say, this should have been offered to me from day one. I think that every single cancer patient should be required to see a psychologist to recognize how impactful this is on mental health.
Yep.
And I get that. I also see people who decline a mental health referral right after diagnosis. Too busy, too overwhelmed, too scared. They want to focus on what's right in front of them and on what they can control, which is fighting and going ahead with the treatment plan. There are a lot of people who are so profoundly overwhelmed by the diagnosis and jumping right into treatment that they do not even necessarily think they need that support.
Yeah.
So just like with everything, it does depend, and different people are going to want different things at different times. Some people will initially decline a referral and then later realize, you know what, this is actually more, I thought I could handle this initially and I was doing really well at first. But once I finished treatment and there was so much unknown and so much less structure, then I realized, oh, wow, I really need to talk about what I've been through.
Yep.
You do find for a lot of people, they think when I finish active treatment, there will be a sense of relief. But for most people, that is overshadowed by the experience of everything kind of hitting them. Going through cancer treatment can be incredibly rigorous. For example, chemotherapy on a set schedule, every 2 weeks, every 3 weeks, every week for 2 to 8 hours, Radiation can be 5 days a week, every single day, driving to the cancer center. And sometimes a lot of people will say that I just didn't have time to process what I was really going through. I had to follow the schedule. I had to stay focused. I had to stay strong for my partner, for my family, for my children.
Yep.
And then once the schedule opens up a little bit, it kind of all hits.
Sure.
And that's when a lot of processing really happens. And that's when a lot of people will realize, hey, I think I might actually need to work through this with someone.
Yeah.
So I think that there are a lot of entry points. When people struggle observably early on to the point where their doctors and nurses and families are noticing, they're so depressed, they're not taking their medication, or they're so anxious, they're not sleeping. A lot of times a referral will come sooner.
Yeah.
So it can come from all directions. It can come from the healthcare team, it can come from the person themselves, or it can come from a loved one who's really worried and wanting them to get help.
And do you find that, let's take the example of someone who starts maybe once they have the time and they've gone through their treatment and they're now like, wow, I do need to talk to someone. Mm-hmm. How long do they stick with you? And I'm sure that depends too, but do you have some patients that it's like they're with you then for years, and maybe it's the fear of recurrence and maybe it never recurs, but they still work with you? Or if it's part of a center, does the hospital have guidelines around, well, you can get treatment up to this point, and then, because I'm sure there's bandwidth and, you only so many therapists. So I'm curious how that works. And if patients have like a cutoff time when it's like, you're done with the psychological part too.
That's a great question. I don't know that anyone would ever say they're 100% done with the psychological impact of cancer. It is pretty normal for the emotional distress to go down over time with blips where it goes up. A follow-up visit, a follow-up scan, a blood test. It's pretty normal for that to go up, and then when everything is fine, for it to go back down. Some people will really be focused on symptom management. So they're going through treatment or they finish treatment and they're really struggling with anxiety. They're really struggling with low mood or depression. And so we will begin working together, really focused on treating those symptoms. So I operate primarily with 2 psychotherapy approaches, cognitive behavioral therapy and acceptance and commitment therapy. And then, as I mentioned, with my background in yoga and mindfulness, I'll bring in those approaches as well. And so with those frameworks and tools that they include, we can really support people in managing their symptoms, managing anxiety, improving worry, reducing catastrophic thinking, lifting mood, improving engagement in social activities, reducing insomnia. And so for many folks, that is the primary thing that they need. And once they get their symptoms a little bit better under control, then they feel that they don't really need therapy anymore. So I can give you an example of a gentleman I worked with. He went through treatment for lymphoma. And during the treatment, he had terrible anxiety, terrible depression, and terrible insomnia. And so we really worked weekly, intensively for many months, focusing on teaching him the cognitive behavioral strategies to reduce his catastrophic thinking, which helped. Now, his symptoms were so high that we also referred him to a psychiatrist in our team so that he could get medication treatment as well. Now, once he started getting better, he suggested, I'm starting to feel more like myself. I think we should meet less often. And so we started meeting every other week, more for check-ins, reinforcements, maintenance, and then eventually to every other month, and then eventually once every couple months. Now, that's a great example. On the other hand, I have another woman that I worked with recently, lovely, lovely woman, super high achieving, lifelong perfectionist. And so we worked on symptoms, but after we had really improved her symptoms, we still had a lot to talk about. The therapy course, as we call it, kind of like you would say a course of antibiotics.
Yep.
The therapy course can vary widely depending on where someone was at in their life before cancer and what they need since going through cancer. And that can change over time. And so the methods, the approach, the dynamic can change over time as well. So it depends.
Yeah. That should be the title of the episode. It depends. I'm curious too, and speaking about this, I imagine, right, patients are coming to you and they're needing your help. and they're learning a lot from you, and you're giving them strategies, and you're probably helping them a lot. Do you learn from your patients? Is there like a
Definitely.
reverse thing there?
Oh, definitely. There's so many things I learn from my patients. I'm pretty active on LinkedIn, and I tend to do some sort of reflective posts about things that I learned from therapy, working with my patients, or things they learned from me,
Mm-hmm.
various success stories, things like that. And I learn so much from my patients, and I get so much inspiration from them. Now, I hesitate to say I'm so inspired by how strong they are, because that is a very controversial and often unwanted statement among people going through cancer, who will say, well, I'm not strong. I'm just doing what I need to do. Like, what's the alternative?
Right.
I'm just going forward with the cards that I was dealt.
Yep.
In breast cancer survivorship, we know that living a healthy lifestyle and maintaining a healthy weight are very important in reducing the risk of recurrence. So there was this lovely woman that I worked with, and she was dedicated to exercise. She would walk every day. And we recently connected after several years having not been in touch. And she told me that, it was really great catching up with you. I'm heading out for a walk. And I said, you know what? That's not surprising me at all, because that's just how she's always been. She took what she could control and made that her priority. In cancer, so many things feel out of control, but there are always things that we can control. And I thought about her on days when I was struggling to work on my own goals, right? I want to exercise more, or I want to get out in the community more. And so I think about the people that I work with and the determination, the resilience that they have. And it absolutely inspires me. And I also really try and practice what I preach. So if I recommend someone exercise to help with their mood, if I recommend someone get out even on a gray day, I try and do that too.
Yeah.
I think that we all should do the best we can to practice what we preach, even though it's tough.
Yeah.
It can be tough for everyone because we're all humans. I always joke, if changing behavior was easy, like no psychologist would have jobs.
Right.
I also say that if I could wave a magic wand and cure your cancer, I totally would, even if it would put me out of a job.
Right. Was that like a go-to phrase for you, if I could wave a magic wand in therapy? Because I know for me, I've been in therapy before, and things like anxiety, things like that, and I would really need reassurance, right? And the therapist would, the phrase I heard all the time was, "I don't have a crystal ball," and I didn't like hearing that, because I wanted the absolute, this is the way it's going to be, which obviously is impossible.
And I would say that people with cancer want that too. They want their doctor to be 100% certain that they got it all, it's all gone, and this was a nightmare that's going to fade into the background.
Yeah.
Human beings, generally speaking, on psychology, do not like uncertainty. No one likes that. I mean, there's a few sort of thrill seekers. I'm not really one of them. I don't like roller coasters. I don't want to go bungee jumping,
right.
Much to the dismay of my husband, who wants to skydive. No, thank you. We don't like uncertainty. And you could do a whole episode and speak with a neuroscientist about why that is, why our brains are designed and do not like uncertainty. But the not knowing is what's hardest for a lot of people. Not knowing what's going to happen, how it's going to feel, is there going to be pain? Is it going to last? What symptoms will I have? What symptoms will I not have? What's going to happen in the future? And that raises another big topic, which is, how do I plan? Okay, so they say I'm a cancer survivor, they say I'm in remission, or they say I have no evidence of disease. How do I plan for the future?
Right.
How can I plan anything knowing that I could get shocked or surprised with a health complication or cancer all over again? And usually what I encourage people to do is to break your planning up into a couple different types based on range. So this week, this month, 6 months, a year, and then sort of long-term dreams that we really don't know if we'll get to that dream or not. Because when you group all your plans into one, then it does feel impossible.
Yeah.
Because with or without cancer, life is full of unpredictabilities and inconveniences and unexpected health challenges. But when you break your planning up into zones, you can have a lot more control. accept accommodations, right? There are a lot of people who love to travel. Actually, an oncologist that I worked with when I was a student, she started a side hustle, if you will, as a travel agent. Like
Wow.
she built a travel business because in her work as an oncologist, what many of her patients were telling her is that they didn't want to lose their dream, their sort of goal that they had waited for, retired for, saved for, of traveling. And so that became her side business, to not just saving lives and treating cancer, but helping people go on their dream trips. What can we do to make that happen? Yeah, sometimes we got to get insurance for the tickets, the plane tickets. Other times we got to use a wheelchair. And that's okay, right? There are a lot of people who struggle with that,
Sure.
whether that they feel like that means they're giving in or they're giving up. But a wheelchair can just be a wheelchair. It can just be a device, and it can be a device that helps you do what you want to do. I do have this discussion a lot with some of my folks who have more advanced illness or who are just more sick, because it feels for a lot of people that each step has so much meaning. But sometimes a cane is just a cane, a walker is just a walker, a hospital bed is just a hospital bed. A hospital bed doesn't decide what happens with your disease or how long you live. It's just a bed to make you more comfortable.
Yeah.
So I do a lot of work with folks around taking negative meanings and attributions off inanimate objects that can potentially allow them to achieve their goals and dreams while living with cancer or other health conditions. So that's another thing that I talk about a lot.
Yeah. And I'm just with that example of the wheelchair or the walker, I'm thinking of myself. If I see someone in, let's say, in a wheelchair or with a walker, I'm not thinking about it even half a second after I pass them. Right? And I know it's very different, right? Like we all maybe think on ourselves, we're more focused on it, right? But and then we project that onto other people. But I mean, there's probably tons of examples where, you know, it's just something existing, and in a moment you notice it, and then you move on. To the average person, like they're probably not focusing on it as much as the patient is.
Absolutely. And I think fear of judgment from others is a very important component, which you just described. But there's also, unrelated to others, the internal judgment. What does that mean about me, to me?
That's a great point.
That I am at that phase where I need a cane, a walker, or some other assistive device. And does that mean I'm giving up my independence, or I'm weak, or fill in the attribution? And attributions are extremely powerful. According to the cognitive behavioral model, the way we interpret our life, our experience, the minuscule things that happen in our day-to-day life is the foundation of depression and anxiety or mental wellness, right? Your boss sends you an email and says, hey, I got to talk with you first thing in the morning.
Ew.
Right? Right? Exactly. 99% of people are going to jump to the conclusion that, like, yikes, I'm in trouble.
Mm-hmm.
But it's very possible that it's something positive. And it's also very possible that it's completely neutral, that they sent you the email to prompt themselves not to forget that they need to check in with you on a completely routine matter. So people forget that there are neutral reasons for things. People tend to jump to the negative, which amplifies anxiety and depression. Totally don't consider that things could be positive. And then, of course, forget the neutral. So attributions and the appraisals, to use the classic cognitive term, appraisal, how we appraise and evaluate every single moment of our lives can play a foundational role in our emotional well-being and our experience of anxiety, depression, cancer, survivorship.
Yeah.
It's really important.
Yeah. I have a couple more questions for you, kind of about the post-treatment.
Yes.
And because we've talked about, you know, fear of recurrence.
Yes.
And we've talked about, you know, what happens afterwards with, like, still being part of the healthcare system, sometimes seeing a psychologist. Mm-hmm. So my first question is, do you find that post-treatment, do people tend to go back to, I don't want to say like their normal lives, quote unquote, but to the way that they were pre-diagnosis? Do you find that eventually they make it back there? Or are they this experience has changed them in a way where maybe they live differently, they approach things differently. What's been your
I'm
experience?
laughing
You're going to say
because
it depends.
it depends. I'm sorry.
It's fine. Yeah, let's get into
I
the
would
nuance.
say, I would say that there's a range of responses. And I don't know that I can tell you exactly which people have which response. I think it varies and it probably depends on a lot of factors. But I would say, yeah, there are some people who go through cancer and over the course of months to a year or so, they will generally integrate back into their normal life. They maybe have more heightened attention to their health or their wellness. They may have changed some of their habits, but their symptoms of anxiety or depression do go down and they kind of go on with their lives and mostly do fine unless there's a health scare or unless something else comes up. For a lot of people, they refer to a new normal. So not normal, but a new normal, which has some elements of how they viewed themselves in their life before cancer and some things that have been changed for the long term or maybe permanently. We can talk in this topic a lot around body image. So people will have scars, hair loss, skin changes, parts of them that are removed. There are a lot of different ways in which cancer can have a really lasting impact on a person, physically or emotionally. And so while some people definitely do go back into the normal life, and after a period of time, cancer feels, like I said, like a bad dream or something really in the past, I would say it's more common for cancer or the issues it caused for a person to stick with them on a somewhat regular basis, something that they need to navigate, manage, and explore. A big topic in my world is sexual health and intimacy after cancer. Sexual health is getting a lot of attention lately. It's one of those topics where people would say, well, you should just be happy to be alive. You know, sex is just, it's just extra.
Yeah.
And we are feeling more and more strongly that that is just not the case. And it is normal and reasonable and wonderful if a person has gone through cancer treatment and still, at any age, wants to pursue sexual intimacy. So this is rapidly growing, getting attention in social media, in conversations, in grants, funding. Big important topic.
Yeah, no, that's super interesting. And it goes back to what you were saying about we don't just want you to quote unquote survive. We want you to live the best life you can and enjoy it. And
related to that, here's what I say about when I'm working with someone who has fear of cancer recurrence. What I say is, among other things, even if we knew for sure it was going to come back, we don't know when.
Right.
So do you want to live that unknown period of time worried and overwhelmed and sad and scared? Or do you want to live as much as you possibly can until, when that happens? My guess is that if you have the choice, if time will keep ticking, and if you can't control whether it comes back or not, you're going to want to look back and feel like you did the best you could to enjoy life as much as possible during that time.
Yeah. And that actually was the second part of my question, was the piece about time, which is I'm curious if as time goes by and, you're going for your scans and, you're getting clear scans, 2 years goes by, 5 years, 10 years, do you notice a change? Do people notice a change? Does time help? The fact that more time goes by, it's almost like you mentioned, cognitive behavioral therapy. I've mentioned some of the therapy I went through. A lot of it was anxiety related, and we did exposure as ways to get control of it. And the more that you proved, at least for me through the exposure, the more you proved to yourself that the fear didn't come true, the easier it got. And that I think has to do with time. As time goes by and you keep noticing, oh, I'm okay, I'm still okay. Does time help? I don't want to use the word heal, but does time help?
I actually really like that nuance that you put on it, helping versus healing. I think time is an important factor. In general, when we think about psychological adjustment to trauma, for many people, time is an important factor. Just distance, space, normal for that person, normal experiences. I think we do people a disservice when we use the old adage, time heals all. I don't think that's true for all people in all cases, but I do believe that distance is a helpful factor. We talk about grief in the world of cancer, but also in general mental health. And what the research says is that, quote, normal grief is about 12 to 13 months, that over approximately a year, many people who have had a loss of whatever kind, the average person with about a year of time will be able to go back to their relatively baseline level of functioning. And I would say for a lot of people with cancer, as I mentioned, some people with time and distance and no other health scares are able to reintegrate to a very large degree in their normal life. A lot of the folks who end up meeting with a cancer-specific psychologist are the people who don't experience that type of adjustment, who get stuck at any point of the journey or on any particular issue or problem. So a lot of times we talk in therapy about what is getting someone stuck. And then once we identify that, how do we help them get unstuck? Exposure therapy is a very fantastic, scientifically supported approach. Now, sometimes people in the cancer world will get criticism for using cognitive behavioral therapy, which can include exposure therapy, because it's based on the idea that if your thoughts are unrealistic or sometimes referred to as distorted or maladaptive, that is the source of your anxiety. But for a woman diagnosed with ovarian cancer, which has a known recurrence rate of 80%, wow, being scared about the cancer coming back is not distorted or maladaptive. It is a real, valid concern. So we have to be really careful with the language we use when we talk about people's fears, specifically in the context of cancer, because people's fears are often reasonable. It's just a question of what we do with those fears, how we manage those fears, how we live with those fears. Yeah. So does exposure and distance and time help? I would say it does to some extent and for some people. But a lot of people need other tools and other resources to continue moving forward, to continue managing those thoughts and worries and fears. And when I am working with folks like this, a lot of time that's when I shift over to my lens of acceptance and commitment therapy, which is really based on the idea that we can't always change or fight with our thoughts. Thoughts are not facts. So if I have a headache and I think, oh my God, the cancer has spread to my brain, that's just a thought. That doesn't mean it's true. And I shouldn't treat my thoughts as foregone conclusions that will then unleash a whole storm of panic, fear, dread, sadness, and anxiety. So sometimes our thoughts are just our thoughts, and we simply have to redirect our attention through specific therapeutic tools, through mindfulness approaches, to what's here right now, what's true right now, and to engage in what we call values-based living. Everyone has different core values, different things that are important to them, that make them who they are, that we use, as they say in this technique, as a compass for our lives. For some people, it's faith. For others, it's fitness. For others, it's giving back, community, nature, animals. Everyone has their own set of values. And when you tune into your values, it can really help give structure and meaning in the face of a lot of uncertainty about health.
So a lot of what you're saying, it's making me think too about not just the patients, but the families and the people in their lives, which we could probably talk another hour about. So maybe that's another episode is the family or the loved ones piece of it and their perspective.
Absolutely.
But I do have a couple other questions. The first one is, and basically everything we've talked about is kind of related to this question. So you sort of already answered it, but I think it would be a nice sort of like summary sort of thing. But I'm just thinking if someone is listening and they are struggling right now with the fear of recurrence, What is something that, or a few things, what would you want them to know about the fear, about what they're feeling? What would you say to them?
I think the first thing I would say is you are not alone. You're not abnormal, not weird, not crazy, and you are not uniquely flawed. This is a concept from Kristen Neff's work on self-compassion, which is extending the same patience, generosity, love, and tolerance to yourself that you extend to other people. There's another component to it, which is you are not uniquely flawed. If you're suffering with something, if you're bothered by something, probably other people have or will experience similar things. If you're having a hard time getting up to exercise, even though you know it's critically important in cancer survivorship, probably other people have too, right? Because when we put these attributions, these appraisals on ourselves, you're lazy, you're unmotivated, you're not worthy, that actually decreases our motivation to do the thing we need to do, and it's a vicious cycle. So you're not alone, not crazy, not weird, and not uniquely flawed. There are many things that we can do to help, things you can do on your own, books you can read, what we call bibliotherapy, and mental health specialists who have particular expertise in this area, who can really offer you tools to help you feel empowered in navigating the thoughts, the fears, the worries, the hesitancies, to reduce the avoidance, to allow you to live as fully as possible, even with these thoughts, even with these worries, even with the unknown.
Yeah. So on the show, we always like to wrap with a little bit of optimism,
Yes.
or what I like to call the "it's going to be fine" moment.
Yeah.
Now, obviously, cancer is a very complex topic, and we can't really simplify it into, "Hey, Dr. Kacel, is it going to be okay or not?" Right? Like you said, it depends. There's so many things. So
Definitely.
I think in the context of this conversation, the way I would frame it for you of the, it's going to be fine, is what gives you hope when you work with people navigating these challenges every day?
One of my favorite things to experience is the look on someone's face. We've been working together in therapy for a little while, and the look on someone's face when they tell me they feel like themselves again. And that can be they've gone through cancer, they're in survivorship, they're hoping they'll never deal with cancer again, and they've reconnected with themselves. Or it can be with someone who is never going to be cancer free and is living with cancer as a chronic condition that might affect their life expectancy and is definitely going to affect their quality of life. And yet they have found themselves again, even in those circumstances. And that is one of the most beautiful things to witness as a therapist, that there are always going to be things we can't control, but there will always be things we can control. And holding on to those things, holding on to hope, which can take on many different forms, is critical. So I encourage everyone to use all the tools at your disposal to feel, as the name of my practice, PAIR Health Psychology, purpose, empowerment, acceptance, and resilience, no matter what phase of the journey you're on with cancer or with any other chronic health condition. Use the tools at your disposal, from support from your loved ones, from close relationships with your healthcare providers, to seeking mental health support and psychotherapy. Use the tools that are out there that work to feel as good as you can, as much like yourself as you can, no matter what you're dealing with medically.
Dr. Elizabeth Kacel, thank you so much for having this really important conversation with us. I learned a ton. I'm sure the listeners learned a ton. I'm really grateful that you shared some of your work with us. So thank you.
My pleasure. Thank you so much again for having me.
My thanks again to Dr. Elizabeth Kacel for joining me today. And before we wrap, there's one more thing I'd like to share. This episode is dedicated in loving memory of my dear friend Alayna, who passed away recently after her own brief battle with cancer. Alayna, or as she was listed in my phone, One Layna, was a one-of-a-kind human being. I met her at a time of transition in my own life, and her presence and friendship allowed me to come out of that time stronger, happier, and more confident. She was fiercely loyal and taught me what it means to pursue your passions and truly live in the moment. I'm so grateful for the last time I got to see her, which was in her element as a mom. I witnessed how much she adored her kids, shared in their giddiness and excitement, even over the small things like unique ice cream flavors, and how she just lived life with a smile. Alayna, thank you for the friendship, the laughter, and the example you set. Our world won't be the same without you. Thanks again to everyone for listening. We'll see you next time.